morning. Welcome back to another episode of Uncensored Truth in Medicine. I am Dr. Mollie James. Today, I'm honored to have our guest, Dr. Katherine Welch. Dr. Welch is a board-certified pediatrician and has a fascinating background. So I will just welcome her in and we will get right into it. So Dr. Welch, thanks for joining us.
Yeah, it's my pleasure. It's great to be on someone else's podcast for a change.
Absolutely. So tell people your track after your trainings. Let's start with your training, but then your track after that to me is fascinating because you took the road less traveled. So just kind of start there.
Yeah. So I went to med school and then did pediatrics, but I didn't think I was going to be a pediatrician until I went into med school and then went into med school. I'm like, oh, I like peds. And then I thought, well, I didn't know what I was going to do. But then I did a couple of international rotations, one in fourth year med school and then one confirmatory rotation and peds residency. And then so right after my training at UAB, University of Alabama, Birmingham, I did not pass go, did not collect $200,000, went straight to the mission field on the Thai-Burma border and went to a bush mission hospital right there in Songkhlaburi, Thailand. And so then went from pediatrics to, it's doing, basically we're two doctors we were doing the surgery, the anesthesia, delivery babies, like all kinds of stuff. It's pretty awesome, actually.
Yeah. So the Burma,
Thailand, yeah, or Myanmar as we call it now. So basically right in Southeast Asia, it's not the Golden Triangle. It was further south. But then and still now, there's quite a lot of refugees, stateless people, internally displaced peoples, and people going back and forth.
So paint us a picture because, when we're in America, we kind of think of a hospital as what a hospital is to us, which is a big central building, very sterile. So kind of paint the picture for what kind of environment, like what kind of facility did you have? And how did they care for patients there?
I mean, you think it's not a bamboo hut. It was a concrete structure and patients came in and the charts were basically half sheet paper like this. And then they were connected and everything was written out and we had charts, they had chart numbers. And so we had people that were regular patients. I even had people who were migrating back and forth between Burma and work in Thailand. And, would say, hey, where are you coming and going? And they would pick up their blood pressure medicine or whatever. But it wasn't by appointment. People started lining up and showing up. We had a waiting area. And then the exam rooms were divided by small walls or curtains. Mm-hmm. And there was a procedure place. We had a portable EKG. We had EKG portable, and then a portable X-ray. That was our only X-ray. Mm-hmm. But it was anything that, like, this was back in 2000 when I went, right? So, but if you could have equipment that was 20 years before, but anything too modern, like right now, everything's like connected and smart on the interwebs and everything like that. But I mean, the hospital currently, I've been back there recently and it's a lot different now, but back then it was it was concrete structure, but they built structures so that it wasn't so hot. I mean, it was in the mountains, it was hot, but it wasn't like you think Thailand, like sweltering, muggy heat. It was that, but you just live there and it's okay. But basically it would show up at the hospital. It was a Christian hospital. So there were devotions and then you round and then you saw outpatient and then you took a break for lunch. And then, but there were surgeries. Sometimes there was emergency surgeries or they would schedule surgeries like hernia or something like that. And then there was a surgical suite where they tried as best we could. It was closed down, no windows. It was the only place where there was an air conditioning unit. And then we had a couple isolation rooms for tuberculosis. But there's some interesting quirks there. So like, for example, I'd be on rounds and then I'd look up and then like all the staff was gone because the food truck had come. There's no like supermarket, but the food came on trucks. There was like a meat truck, a vegetable truck, and then the fish, the motorcycle with baskets on the motorcycle would show up. And then that's how your staff, they had to get their food to cook. Right. And so you look up and you're like, okay, pause on rounds. And you just couldn't, that's just the way it was. And so yeah, it's hard to explain because we all took it very seriously. But at the same time, you couldn't take yourself too seriously. Um, and there were two wards, major wards with about 20 patients each, several isolation. And then behind the hospital, there was what we called Sala patients. So patients from Burma or far away in Thailand or something that needed daily observed therapy, DOT treatment for tuberculosis. Or maybe they had severe wounds that needed dressing changes or wound care, but it was too far away. They couldn't go home. But they didn't need to be inpatient. And so they kind of just squatted around the hospital grounds, or they found places to live in the village or wherever.
Mhm.
And then it was a small village back then. There was no internet. I remember driving my motorbike 18 kilometers to the main town for like dial-up internet, 3 times a week. So, and then even then, sometimes it didn't work. And so you might get email and, I don't know if you guys remember email back then. It was just like black screen with green letters. Yeah. So
Right.
yeah. So anyway,
And how can you say,
I could
right?
go on and on. I was trying to write a book, but, just painting a picture where we did have medicine and we were very serious but it wasn't, we did what we could. You had to be very clinically astute because we had no eye stats. We had no electrolytes at all. I mean, it was, electrolytes were a send out lab to a place for, hours away.
Mhm.
Right. So we could do basic hemoglobin, hematocrit. We did blood typing. And then you had a list of people and their blood type and when was the last time they donated blood.
Mhm.
Um, and but we had a pathologist. We basically trained village people to look at slides and to see what kind of malaria it was, right? Um, and then because we had all the kinds of malaria, falciparum, ovarium malaria, whatever. Yeah. And then all kinds of things, leptospirosis, and it was all very much clinical and saw all kinds of, yeah, saw everything. And so it was interesting that when I went back as a resident, then because the house service would consult ID and then ID would consult me because the only one who'd seen tuberculosis, the only one who'd seen malaria, only one who'd seen measles, the only one who'd seen things. And, we'd have the occasional, it was a big children's hospital. Um, and so that was pretty fun. And I picked up TB meningitis just because it was a gut feeling, like, when you've seen it and you do the test and, you just kind of pick up that kind of stuff.
Yeah. So one of the things when I was doing a mission trip, I didn't realize there's no nurses to take care of patients. So the patients had to bring a family member if they needed
Mhm,
assistance. The family
mhm,
would do
mhm,
their laundry and would bring them food. There is no service like we think of in the United
mhm,
States.
mhm. Yep, very true. Um, we had to like, sometimes you had to if you needed a break, if someone just had to lost we wouldn't do this a lot, but sometimes they just need, like, a little bag, like, for extra oxygen, things like that, but we had a couple oxygen concentrators, that we had to use, but, yeah, they had to do all that, but there was facilities for them, to do that for the cooking and laundry and things like that too.
Yeah.
Sure.
I think it was in El Salvador, and we had our clinic with everyone lined up next to the trauma suite, and somebody had come in and needed a chest tube.
Mhm,
And it blew my mind because they gave the family a list to go get the box that connects to the chest tube, the Pleurovac, for any of you who know medical. And the family went out and bought it. And I'm like, how crude, but yet they can figure out what they need.
yeah,
So that to me was fascinating. And I think to your point, this has been my theory is that anybody who's training in the United States for going through medical school needs to go somewhere like that to hone their physical diagnostic and their diagnostic skills without all the aids that we have because everyone now just comes into the ER and gets a CT scan and a dose of Levaquin. Um, and it really forces you to use cheaper, more cost effective tools when you
yeah.
don't have all those luxuries.
Right. Yeah, and I was really grateful for training at Indiana University because they were doing global health before it was, like, really cool. They had a sister school in Eldoret, Kenya called Moy University, and they had traded, med students and residents and things like that, and so I had the opportunity I went to Thailand, actually, but I thought, well, I didn't wanna go where everyone else is going, but
Mhm.
they had Peace Corps and for missionaries and people like that, just, "Hey, go somewhere." while you have a chance, you get elective. You get med school elective and go somewhere, see healthcare in another part. We prefer that. I mean, you could have gone to France, honestly, but it didn't have to be a developing country, but they really wanted to help people get a sense while you're a student, while you didn't shoulder with a bunch of debt, while you could still get out.
Mhm.
And, I actually then that just I had not a sense that I wanted to do that at all until I went there the first time, and then you're like, "Oh, I okay, maybe I'm built to do this. This is how I'm wired. I could really not everyone could do this, but I think I could do that," and it was awesome.
Yeah. Well, and when you were with us in North Carolina, you said something that struck me too, because in America, we as physicians sign up, we're offered compensation, it's a very straightforward transaction. And you were telling me that you've always had to raise money to support yourself to go do the work you're doing. So can you elaborate on that? Because to me, that's a fascinating concept that's two pronged, right? Not only am I committed to go do this, but I have to find my own financial support so that I can live.
Yeah, and so well, a lot of missions are like that. I mean, that's, most if you call it missionaries, but even doing medical missions, but I would not have been able to do that without the organization called Project MedSend. So Project MedSend, first I want to give them credit because once I was accepted to go abroad, they took on my medical school debt,
Mhm.
because they recognized that doctors or other nurses with a lot of debt would not be able to go to the field and to serve if they had to pay off their medical debt. So, of course, there was a lot of vetting process and application, but I was accepted. And so then once I was free of that, then I didn't have anything else, right? It was just the med school debt. I was just out of residency, nothing else holding me back from going and doing that. But then you're out there and you're raising funds, but I have to say I wouldn't say I enjoyed it, but it wasn't as hard as you think. I could say that doctors have an advantage because you have tangible results. You can tell fascinating stories. People can get their heads around being a medical missionary and the fact that they have less and being willing to give to something like that. But
Mhm.
yeah, so yeah, I have a lot to show for that in terms of life experience. Would do it all over again. And yeah, so it's just, and I was over. I mean, there's a lot more. We started in Thailand, but I was doing that for 22 years, and so as people know, as with your Starlight, getting a good donor base and have people believing in you and the mission that you're doing, and that you're doing what you're called to do, people are really behind you. And my supporters have been with me through every change of my career, and I've been really blessed with that.
That's amazing. So one of the things, as we've kind of come into, or I've come into the world of understanding human trafficking a little bit better, I watched a video put out, I believe it was Judges Rescue, and it talked about different parts of the world, and it's such an accepted practice. And one of the things that blew me away is I believe it was Burma in Thailand. The men don't work, and the plan is to sell their women and children into sex slavery. That's just an accepted norm in society. Did you experience that? And tell us, what did you see on that front?
Some, I mean, what I saw mostly, I don't know that that is norm. I think that happens everywhere.
Mhm.
And I think, I mean, we see that, with the pimp culture and all that stuff. But in Southeast Asia and then in Asia in general is sort of an idea that prostitution is really culturally accepted. Thailand has thousands of years history of paying money for sex, basically the bride wealth, not the dowry that the bride pays, but the men have a bride wealth, right? But it's also 90% of Thai men by the time it's like a coming of age thing of going to see prostitutes, right? My uncle would do business in Japan, and it's like buying a round of prostitutes was like buying a round of drinks. And, and I mean, he would participate. He's a very upright man, but, I remember him talking about that aspect of the culture and that
Mhm.
in Bangkok, it's not that all this foreigners are going to Bangkok, they're there because that was already a culture
Mhm.
it was already pervasive. And there were in the time of HIV AIDS, there were, um, advertisements about condoms and PSAs about watching out for AIDS. And it would be like a couple of women talking about their husbands because they would have mia noise, like minor wives and things like that. And so it wouldn't be polygamy, but it would be, you'd have your wife and then the men would have multiple partners. And
Mhm.
didn't seem like anything like the women could do something about it. And it was very, very common, very pervasive. And so you don't have, it's like, that sex industry is like, this is a very old statistic, so don't quote me now. But when I was in the thick of it, then it was like 14% of the GDP. That was entertainment in Thailand. Of course, Thailand is booming tourists. I mean, there's lots of wonderful reasons to visit Thailand, and you can avoid all that
Mhm.
mostly,
Yes.
mostly. But as far as that whole culture, I mean, prostitution is not legal in Thailand.
Mm.
But yet you have huge entertainment centers, red light districts, huge, like 3-story malls of bars and any which way you can go or want to or desire in just one part. And there were several of those throughout Bangkok where the police are patrolling.
Mhm.
But yet trafficked women, there's the Africans on the street, trafficked for sex, walking the streets. If they got caught with condoms in their purse, then they'd be arrested for prostitution. I mean, yeah, I mean, it's so twisted and upset. Like it's the contradictions and the twistedness and just,
Mm.
I mean, we d- have, we don't have enough time to go into all that, but that gives you a flavor of what's going on. And
Mhm.
women, young girls they're being sold, but they're also, I mean, no one really sells their kid, but they're being told, oh, they're going to work in a restaurant. There's a better life. And so the girls from the north work in the south, and girls from Laos are working in other parts. And so girls from everywhere. And then there's Thai girls in Thailand. There's Thai girls in the Middle East. There's Thai girls. And then there's women from South America or Africa and Bangkok. I mean, Eastern Europe. I mean, and there's a whole hotel that's run by a pimp, trafficker. And, I mean, I don't know if you don't know what you're getting into, if you book a place there, then you're going to find out pretty soon and change your thing. But yeah, so I mean, just going on and on, but it's just a whole pervasive culture of prostitution, which is of course then breeds trafficking. And I
Mhm.
mean, there's no one there just doing it. Yeah, I mean, you have escorts, and then you have 60-year-old women in the poorest, like, slum part of Thailand sitting on a plastic chair, trying to sell tricks.
So, as a physician, how could you engage those folks? Like, what was your actual role to come in as you saw this? That was, I believe, part of what you were there to
Yeah.
do or helping. How do you intervene with those situations?
Well, I was always partnering with an on the ground organization. Some were doing just outreach. Most had a combination of outreach with aftercare service. Some were doing prevention. And
Mhm.
so give you an example. I would join with an organization and we would do outreach, and we would just outreach usually meant hanging out in one bar, or maybe you go to a couple, you sit down, you buy the girl a drink, you just make friends, you try to talk to her, find out about her family, and you're trying to build a rapport and invite her out, right? So that's a lot of what's done. Or you're street walking, you're making friends, you're trying to, sorry, can you hear that? Okay, good. It's the office phone through my computer. But anyway, um, so then but then we would have a clinic, and we would start a clinic about 5 p.m. and we would go to 2 or 3 in the morning. And then there would be a center, an outreach center. Uh, it could be a coffee shop front or something like that. But we would have a clinic there, and I would go on outreach usually a couple days before, introduce myself as a doctor, right? And say, hey, we're having a clinic. And you give them a thing. We're doing free clinic, free HIV tests, because you could get those over the counter. And then they would talk about whatever, maybe they needed asthma medicine, or maybe they needed presumptive treatment for STI, or whatever. And they'd usually come for an HIV test. Um, and it was an opportunity to do outreach, say, hey, we are in, we are in where you work, right? I get it. And like, there's no pretense. You don't have to pretend. There's no shame because going to a regular clinic, it wasn't practical. They weren't up there. They would get discriminated against. They would have a lot of internal shame. And so they would project shame. And so there it was like, hey, you're coming right off the street.
Mhm.
I see you, right? And I see you as a person. And then offering them that service and then offering, say, hey, um, you can leave. And then you can leave if you want. That we have a way out. There's a place for you to stay right now. And always offering them that opportunity. You never know when people are going to take um, that opportunity or give them a phone number and say, hey, we're out here. Come back tomorrow or think about it. Come back next week. We'll be here. And so it was a way of doing healthcare as outreach in a practical way where there's something they could, I mean, I'm not saying it's not good. It's like taking the outreach another step level to meet them where they are. We would do, I mean, I did clinics in bars where they sold boys. We would develop relationships with the bar owner. He said, all right, boys, show up 2 hours early before your shift on this Tuesday night. And the doctors are going to come and do health exams and HIV tests. And then they would just come and say, yeah, I've got some sinus problem. I want this or that. And then it was just an opportunity to build relationships. I would do clinic. I would do exam. We would do a drop-in clinic. There was a drop-in center also for boys or a drop-in center for girls. And then say, hey, Dr. Katherine's going to be here this afternoon. Come and get checked out. Same kind of deal. And so it was just a practical way to do outreach and to meet need and say, and to give them dignity and to show that they were seen and that they meant something and that you weren't just doing talk. We were actually like walking the walk. Does that make sense?
It does. It makes perfect sense. So with such a mission like that and such a heart for basically, I'm going to call it volunteering your services because that's what you did. How did you transition back to the United States and end up where you are now?
Yeah. Well, fast forward, Thailand, China, Thailand, and then Germany. And so this project that I was doing called Relentless. So I'll back up a little bit so that all this was done in the context of Relentless, which is my own organization to demonstrate what does a doctor do full time at the intersection of health and human trafficking. And so it was doing a lot of what I just described, but it was also talking with other physicians and other health professionals how to leverage their unique skills against human trafficking and also training the assistance programs about the health consequences, mental, physical, why do they not get well? What's their issue about how trauma complicates their mental and physical health, that kind of thing.
Mhm.
And then my work was shifting towards Europe because the people in Europe seemed to get this. They got the professional aspect. I was asking to speak. And so then I ended up shifting over to Germany. I lived in Berlin, based in Berlin, but traveling. I was 50% travel when COVID hit. Like I was going all over Eastern Europe, Western Europe, just doing a lot of consultations online, things like that. But COVID, then it shifted to all online. And I was like, okay, what are we doing? And then we're going to get into kind of like what Germany really was. And it was less amount. It was not really like, I really wanted to come back to the States, but it was like, I don't think I have a future in Germany, honestly. And all that stuff is going on there with, not free speech, censored speech and immigration and all their lockdowns. I just like, I was not ever going to be able to do what I wanted to do because of their mandates for physicians to get shots, give shots and do all that stuff. And then all that political climate then just kind of pushed me to look at the United States. And I started connecting with the Global COVID Summit and our colleagues that we know, you and all that. And so getting connected when I was still in Germany, it's okay, I have a medical license. I'm on the front lines of freedom because that's what I've always been about, anti-human trafficking. But it's like looking at the world and where it's going. It's like, yeah, if we don't start to do something, we're all going to be slaves, right? It wasn't just about, poor people from Burma being, trafficking. That is slavery. But it's like, hey, we're all heading in this direction. of global manipulation and slavery. And so I see it. I see other people seeing it. I'm going to join that movement. I'm going to join the medical freedom movement, come back to the States. I can get plugged in. I have a license. I have I have connections, and let's just start. So it wasn't really starting over. It's just sort of a big picture continuation of what I had already continuing. And then also getting connected here on the ground in Indianapolis area, and also connecting, still doing, still consulting more on a big level scale with the anti-human trafficking world, but also really connecting on medical freedom and all the other stuff. And then there's a bunch of other stuff I'm doing too. But so yeah, transition, still transitioning, I guess. You never quite leave it. I was just got nostalgic for Thailand, was listening to some Thai pop the other day, just kind of crazy. But yeah, when I think I'm always on mission. And even though the mission has shifted and the location has shifted, yeah. Has it been easy? No. I mean, no. It's been rough, but still, when you have mission and goals, then you're still on track, and your life still has purpose and meaning. It's just where being present and looking forward.
Yeah. So tell us about where you are now, what you're doing. Obviously, I'm going to put a shameless plug in here that you are seeing patients with Acid James Clinic. Huge asset to the team, so we're grateful for that. But um, yeah, talk a little bit about what you're doing now on a day to day. And obviously, you took a strong stance on the COVID vaccines, which is what shifted you. So maybe get into that a little bit too.
Well, I honestly, yeah, it did shift, although I have to say I haven't suffered professionally as you have or some of our other colleagues, because when I came back to the States, I was already connected with some people with the same stances. So I never had a job where that was being required. I guess
Mhm.
that stance actually prompted me to leave Germany. And so in one way it was kind of an issue. But before it came to that head, I just like, I'm out of there.
Yeah,
I mean, like,
me too.
yeah,
Not me, but
I mean, just going back there, it's like, you're right. I faked tests. I faked everything.
Mhm.
And, you're right in the subway, and the police are checking your papers and stuff like that. And I'm not a very good actor, and I know it's fake, but, they just kind of look and everything. But I just, it's like, I don't want to live in that kind of fear. Like,
yeah.
forget it. So anyway, so as far as what I'm doing now, so currently I'm a solo practice. I run a direct primary care clinic, which means that I'm outside of insurance. I don't accept insurance, including Medicaid or Medicare, for my services. It's cash based, and which means I have freedom to discuss and to treat and to be with my patients for as long as I need to.
Mhm.
There's no like 7.5-minute increments of seeing patients and writing notes and making sure your notes are all like, approved, so you can get that like little minuscule
Yeah.
amount that the insurance wants to reimburse you for all of your work and your effort. And so that's what I'm doing now. I'm in the suburbs of Indianapolis, and yeah, it's going well. It's primary care, but I also have starting a functional medicine branch of it, and then seeing patients with James Clinic. So learning a lot there. But of course, there's all these other side gigs. Relentless continues. Anti-trafficking work continues. When I have time, I do my own podcast, but also getting involved locally with the anti-trafficking work here. I'm getting involved in medical freedom work. I'm a new fellow with Mollie at the Independent Medical Alliance. I'm also a part of the Resilience Health Network, and this is brand new. So I'm going to take a minute to plug
Okay.
this. And that is a group of clinicians that are working on developing guidelines to help detransitioners. These are individuals who have chosen to um, medical or chemically transition to the opposite sex, but then realize that that is no longer what they want to do for various reasons. It's very complicated. Um, but then there's also some medical implications for what has happened, either surgically or hormonally and other things. So we are working to help to restore them based on their goals for their detransition. And so that can be, because this has not been done at this level, at this like number of people, at this to this extent. And so we're a group of primary care doctors, endocrinologists, surgeons, and other clinicians. There's some that are doing the psychological therapy. We're focusing on the medical issue. And so we are officially launching our network online on March 12th, which is D-Trans Awareness Day. There will be an event in DC. Look that up on genspect.org, GENSPECT. And there is an official event, and then there'll be an official launch of the Resilience Health Network. So if you're interested in what we're doing, you can visit the website. And I think probably you'll put that in show notes or something like that. But the website isn't really up yet. But we are looking, if you're a clinician, say, hey, really interested, this is something I can do to help. I want to get plugged in. How can I help? So you can reach out to me and we'll get you plugged in. They'll be vetted. There'll be vetted clinicians, could be doctors, nurses, PAs, or someone who could help. But these are people have want nothing to do with the gender ideology. They want nothing to do with the gender affirming anything. They don't want to go back to their regional doctors because they don't want to be told it's like a transition, an iteration of transition. This is what we're hearing in the gender nonsense. Now, you're not detransitioning. This is just another transition. And it's just, yeah. I mean, like, no. Yeah.
Well,
I mean, because they can't accept that you can't go back. I mean, and you can't go back, but they can't accept that this is wrong. They're just reframing the semantics of what these detransitioners are doing.
Because it's just like COVID shots. There's so much money in the pushing of it, but the pulling back on it is a grassroots effort, right?
Yeah.
There are seminars on how to detransition people. That's what you're filling the gap for people left behind.
Yes, because it's like, and the cognitive dissonance, we can't be wrong. I listened to a talk by a surgeon who used to be in that and was like, oh yeah, this is exciting. This is brand new. And he's like, wait a minute. My patients are not happy. They're not thriving, and they're not thriving after. And then he's like, and then he was caught up in the whole like surgical aspect. Like, yeah, this is what surgeons do. We're just like, it's just bodies that we're working on. And then when he brought in the humanity of it, then it was like, wow, okay. Now he's working to help to restore the surgical aspect. So
good deal. So tell us a little bit about the kind of patients that you see now here in the United States, because again, you pick the most challenging. I feel like you always have the road less traveled. So, but where that intersects with what we're doing, the PANS kids, the vax injured kids, people who have parents who have questions about vaccines. So can you address some of like how you practice and kind of some of the things that you talk to patients and their families about often?
Yeah. Yeah, sure. And that's the great thing about direct primary care is that I do have the time. And I think most of the time as primary care, most of my patients really just want a doctor who will take the time, who will listen, who will answer questions. Because there's a lot of parents questioning. I hear this all the time. Well, yeah, we were doing all the jabs until COVID. We were doing everything until COVID. Or we did everything until like my son had a little bit of a problem or something like that. And parents are just hungry for a doctor that will answer their questions, right? And so they're not all like totally, we don't want anything. They just want someone to honestly answer their questions, who can explain a position. They can, well, are you for or against, or is there a nuance, or are there any shots you would recommend in any circumstance and things like that? And parents are just so grateful for a physician who will honestly listen and honestly answer a question, even if it means like, I don't know, right? And it's about not just about vaccines, but about anything. But then this is what comes up over and over again, and say, well, I give informed consent, and then I'm not going to shut you out if you do give shots. And of course, I'll welcome you if you don't, or whatever you want to do, we work with you. Right. And then, so that's primarily, and then that's then getting started. So you have people who are just like, okay, yes, this is what we want. But then when you're open-minded about that, then you can be open-minded about anything. Because if there's anything, I mean, if there's anything in pediatrics, there's nothing more dogmatic. There's nothing more like set in stone is that vaccines in pediatrics, right? That is it. Like that does not change. Like we cannot like alter our position on anything. It has to be that. So when you're open about that, then and then word gets out like, yeah, Dr. Katherine, she'll look at, she'll look at anything. And so then I get patients asking me about this. And so then and then you get known like, oh, we can take a functional medicine approach. And so that's the great thing about doing primary care is that I have time to spend. And even though they're seeing me for primary care with that functional medicine lens, then I'm able to pick up on things that other doctors wouldn't in the course of a 12-month-old will child visit. Like, hey, yeah, that's not right. Or we should do this. Or what about this? And let's get more. And then you can get on some early testing, or you can get them a referral to some myofascial therapist, or you get them to a biologic dentist, right? You can get them into seeing other things. And so having that for primary care, and then they kind of turn into a functional patient, but not really, because functional medicine is just about getting to root cause, asking a lot of questions, digging deep, trying very hard, and using your skills of your exam and your brain and your knowledge, and also what's on the internet, because I don't know everything, and looking things up, and then looking in, and then people will hear about that, and then they're like, oh yeah, you have this problem? Well, go see Dr. Katherine. So, okay, so then mold or Lyme or people who have been to see other functional doctors and they're not better yet. And so they come to see me, maybe, and it's not that I'm better. It's just a different set of eyes, a different way of thinking, a different approach, new approach. Like, hey, I heard about this. Let's look at this, things like that. And then, so then it becomes more, then I get consults specifically. Mostly it started as vax injured long COVID, right? Because that's what I've always been doing. I was doing that the previous practice. I got known for doing that because that is a niche that I could fill first and then what I knew about. And so people are coming to me like, hey, is this the COVID? Then they have all these weird stuff and like, well, maybe it's the shot, maybe not, or maybe it's something else, right? And then you've got to sort it out. And so it's long COVID, long vax. And then it's like, yeah, hey, these seizures aren't going away, or this skin issue is not coming up, or this or that. And then people come see me, they don't know, or they're just like, I am just so tired. Like, they don't know what's wrong. But they're like, my regular doctor isn't figuring it out, or they're just giving me, after vaccines, it's like, my doctor just wants to give me this medicine but I'm not better. Or they're just giving me medicine for these symptoms, but I want to know what's going on. And so probably that's how I get there. I'm not necessarily known as a functional doctor. I mean, in some respects, I'm just known as a doctor who listens and tries hard. Right. So, which is what functional medicine is about. And then you end up saying like, oh yeah, this is this. And then you can start to fit people into categories, but there's a lot that's not, right?
I was blown away at the MedMaps meeting. I think there was a dentist that was talking and talked about little guys, like the 12-month-old, and how important is it the bite and like the kids at their tongues now, and getting that from a dentist perspective changes the entire trajectory of their cognitive performance and
because of oxygen intake and when you sleep and the way that they're eating and the way that they're sleeping and getting enough oxygen when you sleep really helps their brain. This is why in peds, they just have like obstructive apnea, right? And they just take out their tonsils or something like that. It's like, I think we can do better. But she's amazing. And I consult her from time to time. I said, hey, I've got this kid and you wouldn't believe this. She writes back, oh my gosh, that is, it's really interesting. But I mean, these things but now I can take these principles that I learned in the one talk from them at MedMaps. And then it blows my mind. Now I'm thinking like, okay, what did I miss before? But I'm not going to miss this again. Now it's like, okay, look at this early, and then get on it so that these kids then aren't suffering and then on Ritalin later on just because their brains aren't functioning because we could have corrected some initial insults earlier on.
Yeah. So I think of it this way. A functional pediatrician isn't an option if you're having problems. It's just essential to raising your children. And you all are hard to find. I don't even know how many there are in this country, but it's a tiny handful.
Mhm.
And most of them aren't offering that basic primary care, the pediatric care. They're niched into really those tough specialties because they are doing a good job with it. So tell us a little bit about where people can follow you, where they can find you, and then I'll put a
Yeah.
shameless plug in after you're done.
Yeah. No, I appreciate that. And just a comment. I mean, there are pediatricians that are doing just autism or special needs, but they don't do primary care.
Right.
But this is really what I hope to develop is that primary care pediatricians are looking like their job is just way more than that. So, but yeah, my clinic is called Imago Dei Restorative Health. That's IMAGODEI, image of God, restorative health, all about restoring the image of God in people. I'm located my office is in Carmel, Indiana, in the north suburb of Indianapolis. And my other organization is Relentless. It's gorelentless.org. And the Resilience Health Network is resiliencehealth.network. And that's that website for the Resilience Health Network. And what else? Did I miss anything?
Where to follow you on social
Yeah.
media?
Okay. Um, Gosh, I have a Twitter. Oh, my Twitter is at relentlessdoc, and I just do a lot of reposting. But anyway, you can find me there. Facebook, I have a Facebook page, Imago Dei Health. Relentless has a Facebook page. Also, I'm posting a lot of updates there. Honestly, I don't. I have LinkedIn. Maybe I have Instagram. I don't know. I just
Mm.
I don't have a lot of time for that. I just try to stay focused. Don't try to get drawn into a lot of stuff. I just try to post and stay honest and true. And I know that just doing the right thing, people will find me, and I keep doing what I'm doing.
Yeah, very good. So make sure you're following her, check her out. I try to tag you in Twitter and I can
Yeah.
never remember Relentless. So now I've
That's okay. Yeah. Relentless doc. Yeah.
yeah. So make sure you're following her there. And if you had advice, so a couple of questions as we close out today. To me, one of the greatest crimes or things happening in the world right now is the human trafficking. And I think every person needs to have some awareness of what's going on and they need to stop putting their head in the sand because it's an ugly topic, because it is. It's hard to look at and it's hard to hear about. What would be your advice to somebody who truly has a good heart and wants to make a change in the world to get awareness about that or get involved?
I think awareness is good. I think there's a lot of different organizations that have a niche, like a Judges Rescue, Remnant, um, people like that doing more rescue. And then there's aftercare shelters that are working and they're doing a lot of the long-term restoration work. But to be honest, I want people to know that human trafficking can be prevented. And from early days, from when I went to the field in 2000, it's good old fashioned community development. And it's understanding that the vulnerabilities and risk factors for being a victim are the same risk factors and vulnerabilities for being a perpetrator because it stems from that same, like, yeah, I mean, bullies are usually bullied, hurt people, right?
Mhm.
But when you go back and you can help people in school, when you give them good sanitation, nutrition, it reduces the need to migrate. It reduces those push factors. It reduces need to look for something. It reduces fear. When your brains are working properly because you are, from a functional medicine perspective, like it's all about stable communities, stable families, stable income. All these things are good old fashioned community development. Are we going to stop human trafficking? No. Can it be prevented? Yes. Can we help restore people? Can we do a better job of restoring people so that they don't have to come back to it? I don't think we should also conflate human trafficking with migration, which is what's going on now too. Like all these asylum, these are trafficked or they will be trafficked people. But I think it's understanding. So if you want to do something to prevent human trafficking, you want to prevent, human trafficking doesn't start when someone's trafficked or kidnapped from some guy grabbing from a white van, right? I mean, does that happen? Yeah, but does it happen very often? No. It happens with the erosion of family and communities, and people sticking together. So if you're in need, you've got people that are helping you. So tutoring kids, getting kids, in school, staying in school, making sure those schools are like halfway decent, right? Nutrition, understanding all those other things. No time to get you get the point. I just gave a 2-day workshop on human trafficking prevention in Guatemala. So, sorry if I get long winded on that. But that's what I want people to understand is that it takes all these points of intersection, from prevention to rescue and then restoration.
So really start at home and get involved and build the community right around
Yeah,
you so
yeah,
you know what's going on.
yeah. Or go, maybe not your community, but go and do tutoring or start. So have your church do some like after school club or something like that. Just be, kids build resilience when they have stable adults in their life.
Yeah, that is great advice. So I'm going to ask you one last thing as we close out. Is there 2 or 3 things that you find yourself giving parenting advice or information over and over again that we can just highlight as we close out today?
Yeah, I think I I always encourage parents that they are doing a good job because I think parents just think that they're coming to the doctor and they're worried and they're terrified, their kid's sick and or not getting better or this, and I'm like, hey, I'm here to help you, that you're doing a good job. And I just want parents to hear that because I know that no parent is perfect, but I believe that my parents are doing the best they can and they're doing a good job. And I think that can go a long way and give them confidence and saying, okay, yeah, it's fine. But I also ask parents just to give vitamins and don't feed their kid junk food. Um, it's kind of basic, but also, at the same time, I know they're doing the best, but understanding there's limitations. But hey, let's also prepare them for making, help them make the best choices now, and understanding why we make choices now when they're 3, which will help them when they're 13, which will help them when they're 33, right?
Mhm. Perfect. Great advice. Again, where can people website and where they can follow you on Twitter?
So, website for my practice is imagodeihealth.com and gorelentless .org, and Twitter is at relentlessdoc, for my relentless, and you can find connections on those websites for other socials.
Yeah, and we will drop those in the show notes. Dr.
Awesome.
Katherine Welch, it is always a pleasure. We love having you as part of our crew and our team, and you came to North Carolina, so you're just in it all the way from a mission. So God bless, take care, and thanks for tuning in. Catch us next time with another episode of Uncensored Truth in Medicine.
Bye, everyone. Thanks for having me.